Thank you so much, Michael, and thanks to Telus and Longwood for creating this event and hosting all of you. I really look forward to the chance to do this, mostly because this is an opportunity for me also to look back. And we're all so caught up in kind of our daily struggles that we sometimes forget to look back. And you know, it's like climbing a series of hills and mountains. You're kind of focused on one step, one step, one step. Then you look back and you're like, oh my goodness, what a nice view. You know, I've come kind of far here. And then you turn back and you're like, oh geez, all right, a lot of ways to go. Okay, here we go again. But to have that a little bit of an outside-in perspective on what's happened in the United States, both the promise and the perils, and to see if there's some lessons learned. There's no way that you can take one experience and directly transplant it to another system with all of its complexities and all the interrelations. But I think I'll try to at least provide some context that might be helpful. So it is true, Michael talked about kind of 3 chapters, and I'll try to use those 3 chapters as framing for what I talk about. The first chapter, New York City, and what we did there, the 10 years I spent there. The second chapter, the federal government, and what we accomplished there. I was there for 5 years. And now the beginning of this new chapter, where I'm working with, as he mentioned, accountable care organizations, and really focused more on how we can create new delivery models that map onto new payment models. So let's start with New York City. The goal for us in New York City was not adoption of records. I was in a health department. The goal was to improve population health. So we looked at, this was, I was working for Tom Frieden, now the head of the CDC, and Mayor Bloomberg, and we were looking to answer a very simple question, which is shocking how this question does not animate every health organization everywhere. That question was, how can we save the most lives? So think about that. Has your organization asked itself that devastatingly simple question? We do a lot of things. It's a lot of activities. But do we know what is it that we can do that if we take what we're doing from where we are today to where we know other health organizations like us can accomplish, how many lives would we save? What is it that we should focus on? We actually scoured the literature, and we couldn't find anything that answered that question. What do we want healthcare to do that would save the most lives? So when you look at it, it turns out, as an epidemiologist, it's what kills the most people and what is largely preventable still. So heart disease, my dad had a heart attack, grandma had a stroke, right? A lot of people, there's a lot of empty chairs, and once that event happens, right, we'll do anything, right, to rehabilitate the person with the stroke, to put in place congestive heart failure programs. And those are all wonderful things to do for healthcare providers to do, to alleviate suffering, to mitigate the damage done. But isn't it better to prevent it in the first place? So if we wanted to prevent those events from happening, do we need some new cure for heart disease that some pharma company is going to develop? It turns out that we know a lot of stuff that actually work today, we're just not doing it consistently. So what are those? It's the ABCs, right? Aspirin, it's not very expensive, but more than half of people who should be on aspirin are not taking aspirin. It's effective. Blood pressure control, right? Some of the best medications we have for blood pressure control cost pennies. And yet, more than half of people with high blood pressure don't have it well controlled. Not being on a statin. Getting help quitting smoking when you want to quit smoking. A physician's help can triple the chance of success. Those were the issues that we said, you know what? That's what we want to work on. How is it that can we take a public health approach to saving lives through healthcare? That was the motivation for the program that we started. $60 million to roll out electronic health records to the city's poorest neighborhoods, 1,500 doctors. But we knew exactly what we wanted in those electronic health record systems. Here's what we wanted. What we wanted was the ability for the primary care provider to see how they're doing on blood pressure control. Of all my patients with blood pressure control, how many have it controlled, right? You can't improve something if you can't even measure it. So you start with that, and then you work your way backwards. Okay, well, so we want to have that. Well, so you need to collect that data. And we had the biggest electronic health record companies come in to under the archway that said health department. And we said to them, how do you collect blood pressure? And they said, however you like. How do you collect smoking? In the Health and Hospitals Corporation, blood pressure was recorded in 185 different places, in 185 different ways. So there was no way actually to run a report that said of all the people with hypertension, how many have high blood pressure? We wanted the ability to make a list of patients. Give me a list of all my patients with diabetes and tell me if their blood sugar is well controlled or not, if they're on a statin or not. Population health, not just focused on the people on the schedule to see today, right? That transactional type of processing is great for, I don't know, selling shoes maybe? No, even shoe stores now keep track of their customers longitudinally, right? But somehow it's good for medicine. That and fax machines. The only part of the industry still uses fax machines and beepers in some places. And paper clipboards. So we said, this is what we want, right? We want you to be able to collect systematically the patient's medications, their diagnoses, their blood pressure, their smoking status, and be able to remind the provider if the person's blood pressure is high, and like 95% of the time when the blood pressure is high, the doc doesn't do anything to change the therapy. A little bit of a reminder. We want to be able to make a list of patients and give me that numerator and denominator, the denominator, right? Everybody counts. All your patients count, not just the ones who come in to see you. That concept of the denominator was the single hardest thing for EHR vendors in the United States to grasp. One large vendor spent half of their total development dollars achieving what later became known as the meaningful use standards on understanding quality measurement at the point of care. How can you tell me of all my patients, how many of them got the right things? Now the question is there a lot of room for improvement in the US, in Canada, for that aspect of healthcare? There was a really crazy study that was done in Cleveland. As part of an improvement project, they compared practices who had electronic health records to those who were on paper. And they found that for the care of patients with diabetes, there's the kinds of things that everyone knows you should do for your patient with diabetes, right? You don't need to be the chief resident. The first-year intern knows, right? These are the things that, and no one was saying like, oh, I'm going to personalize the care of this patient with diabetes, and I'm not going to, right? No, it was like, give them a pneumonia vaccine, right? Check their eyes. 7% of the patients in the paper-based practices had all of those things done. All 5, 7%. Right, so if we have this half of the room, right, that second row is are the lucky ones. Everyone else, out of luck. And on the practices with electronic health records, it still wasn't good enough, but it was 50%. It was right, that half of the room. Got it. And they were improving faster. So that was the goal, right? It wasn't just to digitize the paper-based process for documenting and billing a visit. It was actually to do something that you can't do if you're not Harry Potter with paper charts, right? My dream is right? You have a wand and you have a room full of paper charts. And just imagine if you wanted to answer that question of all my patients with diabetes, how many of them have their blood sugar well controlled? Think of what you would do if you were Harry Potter. Right? You would wave the wand and say, okay, well, give me all the patients with diabetes. And they would fly out, they'd hover in the air, right? You wouldn't have to go through one by one, pull the chart, flip through. Does this person have to know? Put it back, right? They would all come out. And then you say, okay, all the people with the blood sugar, A1C greater than 9, and they would shoot over here, and they would, right? And you would say, send them an owl. That was the dream. And when I first visited with my boss, Tom Frieden, one of the first practices where we worked with an EHR vendor to put all these functionalities in, we visited the practice. It's a small office, 2 exam rooms, down some steps in Harlem. When it rains, it floods. And I went into her and I said, so, how's it going? And she said, well, it's kind of slowing me down, this keyboard thing, but it's okay, I'm getting used to it. And I said, okay, hey, it's been a bad flu season. Of all your patients who are elderly patients who you've seen, how many did you give the flu shot to? So what did she say? See how many of you know doctor think. What does any doctor say? How good are you? Oh, I'm pretty good. What did she actually say? I don't know. She said, I don't know. I was like, aha! We just spent 3 years so that you can know, right? Here's this tab. You click on this tab. It says registry. Have you ever clicked on that? No, I've never needed to click on that before. Click on that tab, all right? Run a query. Patients who've been seen in the past 3 months. Psh. Those over the age of 65. Psh. Those who've had a flu shot. 22%. So what's the first thing any doctor says faced with a quality report that says 22%? First thing you say. Patients are non-compliant. Good one, good one. That's the second thing. What's the first thing? The data's wrong. Yes, the data's wrong. So here's the thing. When she used to get, and I don't know, maybe there's some health insurance companies or government agencies that produce these kind of reports and they send them to the doctors and the doctor looks at this and says, 22%, huh? Right? You know what they do with that report, right? Into the trash. Except this was her record. This was her notes telling her 22%. And here was the other difference. It was a list of names. It wasn't just the numerator and the denominator. It was a list of people, patients. That's how doctors think, right? That's the strength, and every strength is a weakness, right? The strength of how doctors think is they think in terms of patients, not populations. So we turned that into a strength. We said, here's your population, here's your denominator, and here's the names. And not only the names, click on it. Go look at your last note. So she did. She clicked on the first one. The first one says, she looked at it and was like, well, okay, I didn't do this one. Next, clicked on the next one. Well, she just came in for a drug refill. Okay, next one. Scanning it, looking at it, looking at it. I know I did it, I know I did it. I meant to do it. Next one, well, I'm working on his blood sugars. And after 8 patients, it only took 8 patients, she stopped questioning the truth of the 22%. And instead, she asked the awesome question. What's the awesome question? What can I do to fix it? That's the awesome question, right? She said, can I send him a letter? So that's what we did in New York City. We went to 233 independent private practices. We customized an EHR with these solutions in it, and we helped the practices actually put it in place. Because none of those practices went into medicine, hoping to become IT project managers. None of them. So we're like, okay, we'll do the project management for you. We'll help keep this thing on track. We have a schedule. There'll be others you can rely on. And then there was a global financial, meltdown. There was a Recovery Act, and there was this brief window of opportunity to do something big across from, Alabama to Alaska in the US. And I was like, okay, that's the place I need to be, right? Get thee to Washington. And there was this opportunity, because one of the right things they'd done in that legislation was they had said, it's not enough to buy the EHRs. We're not going to pay for you to buy software. Because really, right, in life, you typically get what you pay for. And if you pay for software, what you get is software. You don't get what you hoped to get out of it, which was like improved health. You look at software. I like to think of it, my 12-year-old daughter came with me on our trip, and I was saying to her, like, we have a piano in the parlor, right? No one ever plays the piano, right? And they certainly don't play it well, right? So it's a little bit like you want to pay people to buy pianos, right? And you can pay, and they'll buy pianos, and the piano industry will do very well, right? But the music industry, on the other hand, will not improve at all, right? So what the rules, that the legislation that we were given was that actually we're not going to pay for pianos. We're going to pay for, it's not exactly music. It was more like we're going to pay people to practice their scales. We're going to have standard chords. We're going to tune the pianos, right? We're going to have 62 regional extension centers who did what I did in New York City in every state in the country, because you need that hands-on technical assistance, these piano tuners to come in and tune the piano and coach you on, okay, let's get started. Monday, are you going to start practicing on Monday? Great, we'll be back on Tuesday and check how that went, right? So we had piano teachers, we had piano tuners, right? And we gave people a voucher to pick the piano they wanted. This is important. We learned from our experience of our colleagues in the UK, where they did much more of a central procurement. And that kind of worked in New York City, where it was a city, 10 million people, we're doing it for 1,500 doctors, and we could say, like, okay, we know best. In the US, if we tried to do central procurement of a handful of systems, forget it. It would have been a nightmare. And as much as the doctors are dissatisfied, one of the great things is when they came to me and said, I don't like this EHR that I have, I would say, well, I'm glad I didn't choose it for you. Right? So that there's an aspect of owning the decision. There's an aspect of picking what works for you, what works in a rural area, urban area, this population, that population, this preference that is not the same. And we ended up having an amazing boom in new products coming to market to meet this, which if we'd done central procurement, it would have been, a few large companies who know how to kind of manage those government procurement processes. So we said, here's a voucher. Here's what we think is meaningful. And we didn't do it based on what the government thought. We created really phenomenal governance, where there was a health IT policy committee with representation from consumer groups, and researchers, and health plans, and employers, the people who pay for their employees' health benefits, and on and on and on, and doctors, and hospitals, and developers. And that group said, okay, these are the set of things that you want. We want to save lives, right? So be able to do those things that I mentioned up at the top, right? Collect these things in a standard way. We want to coordinate care better, so close the referral loop, send information electronically when they leave. Don't kill people, so, have medication-related mostly, 5 medication-related functions around ordering medications through the system, having drug allergy checking, sending prescriptions electronically. As Michael said, a lot of those individual hospitals maybe were doing it, but at that time, the Hospital Association came to me and said, all of these things? You want us to do all of these? Reporting to public health and immunization registries? Oh, and giving patients their own medical records, right? You want us to do all of these things? And they'd done a survey of hospitals, and they said, like, no hospital in America, like some hospitals do each of these things, but like we can't find any hospitals that today do all of them. And they said, you're out of your mind. It's not going to happen. It's too high. The bar is set way too high. The other thing we did, though, was this created a feeling of inevitability. There was a movement. And 82% of hospitals, 4 years later, met all of those requirements. 82%. These systems have been around 30 years. And every year, we made more progress than in the 30 years, past years combined on getting not just the systems, but some of these more advanced functionalities used. And for some of them, it actually matters that everyone's doing it, right? Because then you get network effects. Then you create a new ecosystem. Then you can have any third-party group that says, I'm going to build an app based on the existence of blood pressure and medication lists, right? One of the things that we had was electronic prescribing. I know there's a lot of interest in electronic, rightfully so, around electronic prescribing. It's low-hanging fruit. Whereas Michael said, single digits before we started were getting electronic prescriptions sent. And a lot of the pharmacies weren't ready to receive those, right? Because think about it, it's a two-sided marketplace here. You can have the doctor sending electronic prescriptions. If the pharmacy can't receive it, it doesn't do very much good. And some of our advocates said, you know, Farzad, you got to back down off of this 25% of all prescriptions sent electronically because the pharmacies aren't ready to receive it. And I said, yeah, but they will be if everyone on the provider side is trying to send them electronic prescriptions, right? After the 8th doc calling them and saying, why aren't you accepting my electronic prescription, they will change, and they did. Whereas if you had said, here's a menu, pick 3 out of 10 items on this menu that you care about, right? You wouldn't have gotten that same sense of mass movement that you need to create a new ecosystem. But it's not all rosy. Here's the tough part. For someone who started this, very clear on the outcomes we're trying to achieve. You're still paying people, not for the piano, but you're paying them to practice their scales, implement a decision support. And if you meet our compliance audit, then you will get a payment. And I kept saying to people, look, guys, don't do this. If you're going to do a check the box and get the check, it's a waste of your time and our money. Do it for a purpose, right? Do it to actually do an improvement project around cardiovascular health, around patient safety. Use it to get to a purpose. This is something that helps you get the infrastructure in place to do what you want to do, not just an end in of itself. And yet, the world being what the world is, there were a lot of people who did exactly that. Who said, what's the minimum I need to do to get my product certified? Oh, it says, you know, whatever, give the patient a after-visit summary. Well, that's a, you know, from us, it's like, oh, that's a great thing. It can be a tool for patient engagement, right? It can also be a completely nonsensical, you know, vomitus of everything in the record. And then they complied with the requirement. It meets the requirement, right? But it doesn't make sense. It doesn't make clinical sense. It was just the shortest line to getting certified. And then they push it out to the doctors, and the doctor says, ah, geez, this makes no sense. This government's making me do this stupid thing. Right? So either they will comply, holding their nose, here, patient, here's a 17-page bunch of nonsense, right? Or they'll say, ah, if I hit print and then I hit cancel, it will count. That hurts. As a policymaker, when you see people doing compliance-oriented, that hurts. So here's the challenge. How do you create purpose when the financial incentives are not aligned towards that population health? What I glided over was, remember when I went to her and I said, how's it going? She said, well, I'm a little slower. How does she make money? How does she make money today? Office visit. You document X elements, you send a bill. What is her income revenue completely dependent on? How many patients per day can she process through? How many shoes can you sell in a day? Not the quality of the shoes, not the happiness of the customer, not the necessity of the shoes, certainly, not the safety of the shoes. How many shoes did you sell today? That's our vaunted patient-doctor, relationship has come to that. How many shoes did you sell today? So as long as that's how she's being paid, all of this population health stuff, it's not nothing. I mean, there's intrinsic motivation. Doctors want to do the right thing for their patients. But you can't expect people to go broke doing the right thing. You need the financial and the non-financial incentives to be aligned. And a great deal of, I believe, the dissatisfaction, the lack of optimism in the future in the United States around medicine is that conflict between what they think is best for the patient, truly best for the patient, and what they know they have to do to make a living. And those two are not aligned. What's best for the patient when the patient comes in, that we were talking yesterday, and Sheldon said that the heart sink. The heart sink, when you see a patient and you're like, oh, geez, this person's going to need a lot of work. Their family situation isn't right. What's going on? They don't understand their medications. They're getting a little demented. They're living alone. Jeez, that heart sink. What's right for that patient is for you to spend an hour with them. That is not what is good for the balance sheet at the end of the month, because you don't get paid. The hospital will get paid if they get admitted. The emergency room will get paid. When she has the fall, the orthopedic surgeon will be paid. Right? Everyone will be paid when she gets sick. You will not be paid for keeping her healthy. Not a dime more. So all of this stuff that you're telling me, thanks, doc. Thank you, government. Can I just check some boxes and get a $16,000 check? Right. So that's the third chapter. The third chapter is how we always knew that to make this really work, you need to have new payment models that actually reward outcomes. The simplest definition of value-based payment reform, right, is no outcome, no income. No outcome, no income. But you need the systems to be able to measure the outcome. Because if the only outcome is how much money we're spending, you get the wrong incentives. Right? That, too, is not aligned with what's in the patient's best interest. That becomes, stinting on care that's needed. So we actually need to be able to measure outcomes. And without the data infrastructure in place, you can't measure the outcomes. Right? Without the outcomes, you can't pay for outcomes. Without paying for outcomes, you can't make that infrastructure make sense. So this is not a problem that the market alone is going to solve, because it's one of these chase your tail kind of problems, where you actually need policy to say simultaneously we need to build the data infrastructure with a purpose, fit for purpose, and we need to change the reimbursement model so it aligns with the use of those technologies to get to the societal benefit we hope to see. That's a really hard job. Thank your, government health policy person today, because it's a really, really tough challenge. Now, in the US, in 2009, we had the Recovery Act. In 2010, we had the Affordable Care Act. And as part of the Affordable Care Act, everyone knows about the insurance parts of this, covering people who are uninsured. But what's less well known is there are actually a whole series of experiments, models, and a permanent program called the Medicare Shared Savings Program, where if groups of providers, physicians, primary care physicians, and others, you don't necessarily have to have a hospital in the mix, come together and they take accountability for an entire patient's population, Medicare says, I'm expecting to spend, we just started, we're little baby ACOs, right? We have 25,000 Medicare patients. That is $250 million of healthcare spending every year. Over the next 4 years, that little pool of 25,000 patients are going to cost the government $1 billion. That's how much healthcare costs in the US. Oh yeah, that's $1 billion US. And what Medicare is saying is, we're planning on paying this $1 billion over the next 4 years. If it comes in at less than that, you guys keep half of it. The incentives became aligned. Oh, and if you don't improve quality, you get nothing. Oh, now you got my interest. Oh, and if the patient doesn't like what you're doing, they can leave and go anywhere else. Oh. Right. So now you got to hit that triple shot, right? You got to hit the triple shot. It's got to reduce, right? Better health. You got to give better care experience, otherwise the patient's going to leave. And it's got to be lower cost. That's all. That's all you have to do. Better health, better care, and lower cost at the same time. And I actually think that it's eminently doable, because what we're doing right now is so bad. Right now, there's no one watching out for the patients holistically. There's no one thinking about cost. The primary care docs have no idea what anything costs. No idea. Nor, frankly, much inclination to get involved in that, because they need to sell the shoe. The next customer is waiting. Right? So that's where I think the most exciting things happening now are, is we now have the tools, we have a chunk of the infrastructure. It's not being used for purpose in most places. There's a lot of disgruntlement about that conflict between what really people want to do and what they have to do to make money, but there is now a window that is opening, and we want to crank that window open, where actually doing the right thing makes sense financially and intrinsically to the physicians. So I want to take 3 lessons from our experience in the US away here. The first is paying for actions and behaviors is better than paying for things, for software, for pianos. Doesn't go far enough. And so if there ever would be the opportunity for you to create a program that creates, and so our incentives were on about 100 Canadian dollars per citizen was the Recovery Act, high tech, $100 per citizen, US citizen. if you ever have an opportunity to do something on that scale, either at the province level or at the federal level, there's some advantages to doing it at the federal level, but it may be more difficult. Make sure that it's not, certainly not just buying pianos, but even use and behavior doesn't go far enough. It's got to be tied from the beginning to outcomes. Outcomes that matter to frontline clinical staff, as well as to patients, as well as to society. It's lesson one. Lesson two, if you want people to appropriately adopt and implement, they need a few things, particularly small private practices, smaller practices in general, rural practices. One of the things we did right was we gave them hands-on assistance. These extension centers, these geek squads like mine, right, who went into the office and helped them do the project management, that's indispensable if you want to not have a lot of money wasted on bad implementations. And most IT implementations are bad implementations by definition. So they need a helping hand to do this well and safely. And I do believe that we did it right to give them the choice, not to decide for them top down what this is the system you're going to use. What I would do maybe a little bit differently, what I would put more emphasis on is, one, usability. So we kind of assumed that market competition would favor the most usable products. Kind of makes sense, right? Like, do you want the government regulator telling you what's usable, what's not usable? Or do you want the customer picking the more usable system, the system that's more intuitive for them, that has fewer clicks, that, you know, bugs them less? You would hope that the customer would choose the more usable system. It turns out people have no idea what's usable. So many people came to me and said, I didn't know what I bought until 3 months after I bought it, because the demo looked really good. You know? And I was one of the people who did the sales pitch for us. I noticed that he would click on something, and if it would hang, he in no way, he never clicked it again. He just leaned back in his chair and changed, kind of talked to me about whatever else is going on, and then 3 minutes later, the thing would happen. Right? And the screen would refresh. And then he would seamlessly turn back to the demo. Right? And I was like, wait a minute. Was that the click that you did 3 minutes ago? Right? Now imagine being in clinic, right? And then you click on that thing and nothing happens. And you're like, click, 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 click. Right? Cancel, rewrite. And that's exactly the wrong thing to do, right? And that's the experience that a lot of these docs had once they implemented the systems. And then the other part was, a lot of times, the system was bought with other people's requirements at the forefront. What's good for the CFO for their financial accounting? Oh, what's the vendor we already have a contract with? It's easier to extend that. What's the whatever? Not usability. So make sure usability is emphasized. Make sure there's transparency around usability. Make sure that there's education around usability. Make sure there's pressure on usability. And the third is patience. We've talked, and the Recovery Act was almost all about doctors and hospitals and enterprise legacy IT vendors. There wasn't much in there about patience. And we were like, you know what? We actually had to get the secretary, for legal purposes, to write a little statement that said, the Office of the National Coordinator has authority to work on, basically, patient access to their own information. Delegate her authority around overall health to us to work on this. That's how much it wasn't in the legislation. But we made it one of the cornerstones of the office. We said health IT is not just electronic medical records. Health IT is also increasingly going to be what you and I have in our pockets. This is health IT. Now, this runs on data. If it's in paper, this is not health IT. If the information is digital, and if the patient has access to it. If they can actually get a copy of their own records, put it wherever they want, and have an ecosystem of third-party apps that help them use it, do stuff with it, manage their health, manage their finances, manage their medications, manage their mom's health, message their doctor, get a refill. That becomes incredibly powerful. I was at the clinic where I get care, and the pharmacist gave me my prescription and said, take it at night. And I said, sorry, I'm about 60% compliant when I take it at night because, I fall asleep putting the kids to bed or, on the sofa, with a book. But in the morning, I'm really good, It's like brush your teeth, deodorant, medication, right? I can do that. I lined them up in the cabinet. And he looked at me and said, take it at night. Starched white coat. He's the pharmacist. And I got kind of ticked off. And I said, oh, yeah, what's the half-life? Which means, how long before this substance goes down to half of its concentration? If it's long, it doesn't matter when you take it, right? So he looks at me like, okay. And he's got his pharmacy information system, which I am sure cost some significant fraction of $1 billion. And he starts going to type, and he's moving the mouse. And I can't see anything, right? Because the screen, of course, doesn't face the patient. Or why would it? It's my record. Oh, no, it's your, wait, whose record is this? All right, so he's typing, and like the seconds start to tick away, and it becomes clear that I know, and he knows that I know, and I know that he knows that I know, that I could Google it. Right? So that like starched white coat and the authoritarian, and I'm the one with the information here, right? And you shall listen to me, and I will speak Latin. Like there's Google Translate that translates from Chinese to English like in an instant here. Like there will be a Latin translator, right? That'll tell you what all that gibberish means, right? So what it's really about is a power dynamic that's shifting between medicine and the patient and their family members. When my mom was in the hospital, I would do anything for her, right? But the message that I was getting from the hospital staff was what? Do nothing, all right? Do nothing. Just back off, buddy. We got this, right? And they didn't got this. Anyone who's ever had a family member in the hospital knows, like, you got to be so vigilant, right? So that's going to be the next thing here. The most exciting thing probably is as exciting as all that EMR stuff is and population, right? It's when we get to patient empowerment, consumer empowerment, building on that technology. And we're going to be here to see it. Thank you.
It's tradition to test you, and now we're going to ask the audience to do just that. So I have a mic, and there's a mic at the back. Who's our first question? Who wants to challenge the guru?
You don't have to challenge. You could do compliments.
Just ask a question.
Yeah, you can ask questions.
Here we go. Takes a minute just to warm them up. State your name.
Okay. My name's Hilary Salter, and I work with family physicians in primary care. And interestingly, I work with moving them from fee-for-service to the Ontario blended capitation models. And the main question I have is, it's awesome that you gave everybody the voucher, and how are all of the different systems talking to each other?
Yeah.
Or are they?
Yeah.
Because that's an interesting issue in Ontario. Interesting?
Yeah.
Challenging? Difficult?
Tough.
Yeah.
Yeah, it's a tough issue everywhere. So when we started, we said, okay, we want to tune the pianos, right? So that when you collect blood pressure here, it sounds the same as any piano everywhere. Middle C sounds the same, right? And a lot of the piano makers were like, oh, fantastic, we all agree. Can it be my middle C? Right? Every standard is fantastic as long as it's my standard. So we didn't have, if one system communicates their medication list to another system, right? This uses one coding system, that used a totally different coding system. Diagnoses, you have the lab tests, the immunizations, everyone had their own code set, vocabulary, terminology, and even if you could move it, right, you couldn't understand that this is the same medication as this, or if you assumed it was, that could cause major patient issues. So one of the first things we did was we said, okay, in the next 2.5 years, and believe me, there will be a single standard. Get on the bus or get under the bus. Do you want to be part of the group that figures out what the single terminology is going to be for medications? We welcome everyone's participation, everyone's voice, but there will be one. Right, so now we have, in the regulations that were passed 2 years ago and are due to take effect, they keep getting pushed back, unfortunately, but are due to take effect for doctors in January. Every EHR will have to use that same coding terminology. The second thing is, how do you transmit that information over? Where do I put the medications? Where do I put the diagnoses? Where do I put the immunizations? Where do I put the procedures? And before, there was almost religious wars over, no, it should be the CCR, no, it should be the CCD, it should be the, right, and these different C32 and these different, and we were like, you know what, we don't care, right? But there will be one. And in this new iteration, there is one, right? It's an XML document with 17 segments and a header. It's not rocket science, folks, right? Everyone has to do that. And everyone's not going to do it exactly the same way, and it's going to take some time for people to clean up for company, right? Once you start sharing it and people are like complaining, right? Like, hey, you put the thing in the wrong place, you idiot, right? Then you're going to fix it, and it's going to iterate towards that, I believe. And the third thing was, how do you actually send it, right? So say you have the terminology, say you have the bucket, how do I send this bucket to you, right? Do I FedEx it? Do I DHL it? Do I take a cab? Do I, and it's got to be secure, and I got it right. So again, we brought people together and we said there are 3 camps. Oh my God. There was the kind of internet-y camp, there was the old school camp, and then there was the email camp, who was like, oh, you know what? We're just going to, how about we just do secure email, SMTP protocols. And these 2 camps really hated each other. Like the traditional people and the internet-y people really hated each other. But they hated the email thing less. So they're like, fine, we'll do the email-y thing. So we now have this email-y thing, right, SMTP protocol, where you can attach securely that bucket and trust arrangements between the different internet service providers, basically. So that was the approach that we took. If we could do it again today, I think the internet-y people would win. But 5 years ago, the internet-y people didn't have an approach that was as well suited for healthcare as it was for e-commerce. But honestly, the compliance issue still comes up. So just because you can share information basically for free doesn't mean you have to. Government's not going to, well, maybe you guys will. We're not going to set pricing on, like, the vendor may have no more than 85 cents for right? So you get into these things where the cost is way down of doing this, but the price is still $20,000 for an interface. Right? So cost can come down, price can stay up. And it gets to the issue of business practices. And are there business incentives for the hospitals to actually share information with their competitor? Are there business incentives for the vendors to actually make it affordable for people to move that information around? So you can do what you can, you must do what you can on the standard side, but you also have to fix the incentives in the healthcare system. Long answer, sorry.
Hi there, I'm Ozzy Balerci. I'm the manager of personalized cancer medicine strategy at the Princess Margaret Cancer Center. Thank you for a great talk. You alluded to it a little bit, but I was wondering where you think the opportunities are if you're a kind of an entrepreneur or a startup in digital health, or kind of wearables or the Uber health type things. Where would you start, and what should you be mindful of?
Yeah, great question. So you should start where there is a business case. And I don't mean to be flip, but so many entrepreneurs start where there is no business case. And they're like, we have this great solution. It's fantastic. It will solve a problem that is a really important problem that no one will pay me to solve for them. So there's so many people who are like, we have a great thing that will help people with diabetes stay healthy. That's fantastic. Society needs that. Who will pay you for that? Think about it. Who will pay you for a technology that will help people with diabetes not develop complications? Is the hospital going to do it? Is a primary care practice, who just made $22.43 on a visit, going to give you money for that? Is the patient? When was the last time patients paid for something on their iPhones? Right? It's all supposed to be free. So find a business case, and they're there, right? And they're often in these little pockets, right? We have this program, we have this pilot, we have this bundle, we have this episode thing, we have this capitation thing, we have this market segment, we have this group of patients who, I'm getting paid so little on that I'd rather not see them, right? Find those pockets where there is. And then the thing to be mindful of is healthcare is conservative for a reason. And the reason is patient protection. Oftentimes that's used as a shield, as a fig leaf, but it's also real. The Silicon Valley mantra of, move fast and break things, right? That doesn't work, right? Do not break things when it involves patient lives, when it involves privacy and security of patient information, right? It goes beyond don't be evil. Like, you just, no responsible healthcare person will give you a chance unless you de-risk it for them on basically patient privacy and patient safety issues. So that's the thing I would say be mindful of.
Way at the back.
Hi. Hello? Hi, I'm Jim Tom, Public Health Ontario.
People.
Yeah. Great talk, and really, really passionate about the whole patient empowerment thing. But my question is it relates to actually the previous question as well. Is given the failure or the non-adoption of patient private patient records systems like Google Health. I think Harvard had a thing going. Telus Health Vault, since we're in the Telus building. These systems have not really been adopted. Can you comment on why that is, given your vision? And I think that probably 90% of the people in this room would agree. But give us your sense of what what that takes.
Yeah. Here's the problem with Google Health. You had to type your stuff in. And there were 5 people in America who actually would type in all of their stuff so that they could then read it. That was the killer app, right? You type it in, and then you can read it. Right? That's what Google Health did. And so there were two problems with that, right? One is that I have to type all this stuff in. And so it becomes really important for us to reduce the cost and the burden and the difficulty of me getting my records, structured data, into my personal store. The person who used to run Microsoft Health Vault once said to me, I joined them because they were the only group that would have the capital and the patience to establish interfaces to every health system in America. Right? Can you imagine the cost of building interfaces to every system in America? Right? The new opportunity here is that we have actual standard containers with the standard terminology, with the standard buckets and the standard approach, and the patient can be the one to say, yeah, give me my darn records. And make it easy from this app, just like you go your banking records. Right? How many of you have ever downloaded? It used to be you would download your bank stuff into a Quicken document that you would then upload into Quicken, right? The new approach is mint.com. Anyone use that? Right? Where you just put in your password, and in the back, there's, it brings in all your account information from all the different places. You don't have to click and download or whatever. So that's creating easy ways for patients to get their records is part one. Part two is, well, now I have my records. Now what? I can look at them? Now, that could be good, particularly if you can let someone else look at them. Like I'm going to some cancer specialty care and I want them to see everything else I've done. That's not bad. But the more kind of modern thing, the reason why we all carry these things isn't because there's static information that we can look at here. It's because there's actually apps that turn that data into something I actually want to do. So what's I think is actually super exciting about Apple's Health Kit isn't that there's some breakthrough technology. It's just that there will be a lot of app developers who in a safe way will be able to, that in a way that protects patient privacy and has the Apple SDK behind it to make it easy for them to build stuff, will be able to build little stuff that will make it kind of useful for me. That will be like, oh, these are your doctors, right? And this is the quality report for one of your doctors. I don't know. Maybe it'll be like, these are your mom's doctors, and your mom will be able to push a button and tell you that she's got a problem, or these are the medications you take, and here, take a picture of this medication, and it'll tell you what that medication is, or it'll there's 1,000 different little cases, not one big grand use case to solve all use cases, but a bunch of stuff that you'll be able to do with that health data on top of that platform. That, I think, are the two things you need. You need the data, and you need to be able to do something with the data that actually makes sense to the consumer.
Dr. Mostashari, it's tradition that we have 1 hour and 1 hour only, but we could go on for a long time, I'm sure. I'm going to turn it over to Paul LePage.
So on behalf of Telus and Telus Health, I want to thank you for joining us this morning. I hope that it's helping you in your thinking about how we improve the performance and the health outcomes of our various systems. Farzad, it's been a real pleasure. I want to thank you for making this authentic, pragmatic, and charismatic, I would say, in terms of your delivery. A couple of takeaways from my perspective. I'd say the first one is we're very focused from a Telus Health perspective on collaboration and how we build collaboration amongst the healthcare providers and, frankly, amongst healthcare providers and patients.
Yeah.
And I think you're bringing another aspect to this, which is the providers, the patient, and society, and the balance there in that intersection for sustainability, which I think is key. Second takeaway from my perspective, obviously, is the notion of liberating the data.
Yeah.
And making that data accessible to everyone. And obviously, my third takeaway is usability and the importance of usability on the systems. And I love it when you wave these things. I mean, that's good for us. We really like that. So
I do it in all my talks.
Yeah, that's good.
I wasn't here.
So we'll have you back. That's what that means. I think this is really the thinking here is how do we step back and as you were mentioning, pause. As we make this climb up. We're at base camp 2 and we're trying to make it to base camp 3 and we're working our way up. And how do we pause during this journey and think back on the things that we need to do? And as Mike indicated, from a Telus perspective, we plan to have more of these Telus Health talks. So we would ask you to complete the surveys give us your feedback. Tell us what we can improve in the way we do these events. And, you know, I'd like to also take this opportunity before I close to thank the people from Telus and Longwoods for helping us set up this event. And if you want to continue this conversation and continue this dialogue, you know, we have our newsletters, we have our Twitter handles, we have our Facebooks. So continue along those lines with us, and let's continue this journey together. Thank you.